Yeah, so that's an interesting question, talking about barriers to intensification in metastatic castration-sensitive prostate cancer. And it's a little curious because we've had data since 2014 that have highlighted that ADT alone is really substandard and insufficient to treat men with metastatic castration-sensitive prostate cancer. Yet there have been a number of studies that have demonstrated that there are, on some levels, maybe only half of patients, even in the United States, or a large proportion of patients who are not getting what will be considered standard of care with either an anti-androgen added to the ADT or sometimes chemotherapy as well. And I think part of the barrier comes from a couple of things. One is, in some communities, urologists are often delivering care, and this is not a slight against urologists. It's just a different kind of disease comfort or disease state where perhaps medical oncologists could be involved more. And I think that would help in terms of intensifying the treatment to match what really are the standard of care. Again, it's not putting blame on urologists. It's just that, I'm a medical oncologist and I couldn't do surgery very well. So I think getting medical oncologists more involved in the care would be helpful. But I also think even when medical oncology is involved, it's not perfect. And part of the reason is because when you start ADT, androgen deprivation therapy alone, very frequently within a month or two, the PSA comes down very low, below 1 or sometimes undetectable. And the patients are already starting to have side effects from that. And there's kind of this sense of, well, this patient's maybe a little older and they're doing very well. Maybe I don't have to add that extra therapy. But this is kind of the siren's call that almost is kind of very misleading. And that is the benefit of adding or intensifying therapy in metastatic castration-sensitive prostate cancer is not demonstrated or coming to fruition in the first months of therapy, rather years down the road. So I think we need to consider that intensification in this setting is almost like an adjuvant therapy, where you're adding it to a known therapy without the expectation that you're going to see a near-term benefit that's necessarily recognizable. But the data clearly shows that adding an anti-androgen or sometimes a chemotherapy to ADT in metastatic castration-sensitive patients increases survival, not just progression-free survival or something else intermediate, but clearly survival, which is the ultimate goal here. So I think in the academic community, we need to do a better job of continuing to kind of demonstrate the data to our colleagues across the country, highlighting that it's not just the kind of the short-term win of getting the PSA to drop and getting control for what maybe 1 or 2 years. It's really the long-term battle over the course of 4 or 5 and hopefully many years longer.